Welcome everyone. In this presentation, we will examine how to identify and distinguish serotonin syndrome from other hyperthermic toxidromes and review the treatment approaches for each. We will also discuss the clinical challenges these conditions present, highlight why early recognition is essential in anesthesia practice, and outline evidence-based strategies that support optimal patient outcomes. Hyperthermic toxidromes represent a group of conditions that share overlapping clinical features: hyperthermia, altered mental status, seizures, and potential rhabdomyolysis. Our main goal when facing a patient with suspected hyperthermic toxidrome is early recognition and rapid differentiation. Understanding the underlying pathophysiology and the subtle differences between each syndrome allows clinicians to initiate targeted treatment and significantly improve patient outcomes. There is a growing need to recognize serotonin syndrome and other hyperthermic toxidromes, especially in perioperative settings. Rates of antidepressant use continue to increase in the United States, and serotonin syndrome often results from unintentional drug interactions. Under general anesthesia, diagnosis becomes more difficult because of neuromuscular blockers, and sedatives mask muscle tone and mental status changes. Additionally, studies highlight the critical role of rapid response teams. The presence of a dedicated malignant hyperthermia response team has been shown to reduce mortality from as high as 80% to less than 5% through early recognition and timely intervention. Malignant hyperthermia is a pharmacogenetic disorder triggered by certain anesthetic agents, most commonly volatile anesthetics and succinylcholine. The underlying problem is uncontrolled calcium release in skeletal muscle, causing sustained muscle contraction, increased metabolism, hypercarbia, and life-threatening hyperthermia. Rapid identification is essential because malignant hyperthermia can progress quickly without timely intervention. Clinically, malignant hyperthermia often presents with a sudden rise in end-tidal CO2, tachycardia, generalized muscle rigidity, and rapidly increasing temperature. Acidosis, hyperkalemia, and rhabdomyolysis commonly follows. Hypercapnia results from a hypermetabolic state and excessive CO2 production due to uncontrolled muscle metabolism. Intraoperatively, an abrupt increase in end-tidal CO2 that does not respond to ventilation is one of the earliest clues, especially if succinylcholine or volatile anesthetics were used. Management of malignant hyperthermia centers on immediate action. First, stop the triggering agent and call for help. Then, administer dantrolene at 2.5 milligrams per kilogram. Supportive measures include increasing oxygen and ventilation to lower end-tidal CO2, applying cooling interventions, correcting electrolyte abnormalities, treating arrhythmias, and monitoring urine output closely. It's also crucial to contact the MH hotline for guidance. After stabilization, continuous monitoring is necessary because recurrence of symptoms may occur in the post-op period. Additionally, the Malignant Hyperthermia Association of the United States provides evidence-based recommendations to guide the recognition and management of malignant hyperthermia. These guidelines are designed to support rapid clinical decision-making, minimize delays in treatment, and reduce variability in care. By promoting early intervention, timely dantrolene administration, and coordinated team response, these recommendations aim to improve patient safety and significantly reduce morbidity and mortality associated with malignant hyperthermia. Neuroleptic malignant syndrome is most commonly caused by a dopamine receptor blockade from antipsychotic medications. This dopamine depletion affects the hypothalamus and the nigrostriatal system, resulting in high fever, severe rigidity, and autonomic instability. Perioperatively, dopamine-blocking agents such as metoclopramide, promethazine, and droperidol account for nearly 40% of reported cases. The hallmark symptoms of NMS include fluctuating mental status, ranging from drowsiness to coma, along with Parkinsonian features such as dystonia and dyskinesia. Autonomic instability may be the only observable sign under general anesthesia, presenting as labile blood pressure, tachycardia, tachypnea, diaphoresis, and incontinence. Laboratory complications may include electrolyte abnormalities, acute renal failure, arrhythmias, and rhabdomyolysis. Treatment for NMS begins with stopping the offending dopamine-blocking agent. Supportive care is essential. Cooling measures, aggressive hydration, and management of complications such as arrhythmias or renal failure are key. Pharmacologic therapies may include dantrolene for rigidity and bromocriptine or amantadine to restore dopaminergic activity. ICU monitoring is recommended due to the risk of rapid deterioration. Serotonin syndrome is another hyperthermic toxidrome clinically similar to MH and NMS, but with key distinguishing features. It occurs due to excessive serotonergic activity in the central nervous system and often results from combining multiple serotonergic medications. Recognition depends on understanding both the pharmacology and the clinical presentation. Serotonin syndrome results from elevated intrasynaptic serotonin levels, leading to overstimulation of postsynaptic serotonin receptors. This can occur through increased serotonin synthesis, increased release, inhibited reuptake, or direct receptor agonist. SSRIs, for example, blocks the serotonin transporter enzyme, leading to higher serotonin concentrations in the synaptic cleft, which is therapeutic in normal doses, but combining them with serotonergic agents can lead to excessive serotonin accumulation and eventually serotonin syndrome. The presenting diagram illustrates how excessive serotonin accumulates when two or more serotonergic medications are combined. The overstimulation of serotonin receptors results in a triad of symptoms seen in serotonin syndrome, as evidenced by neuromuscular changes, autonomic instability, and altered mental status. Various medications used in anesthesia can precipitate serotonin syndrome. These include antidepressants such as SSRIs, MAO inhibitors, as well as certain opioids that include meperidine, tramadol, and methadone. Because many patients present for surgery already taking serotonergic antidepressants, perioperative drug interactions are a major concern. Diagnosis is commonly guided by the Hunter serotonin toxicity criteria. Key clinical findings include clonus, whether spontaneous, inducible, or ocular, along with hyperreflexia, tremors, agitation, and autonomic instability. Clonus is the most specific and distinguishing feature, helping differentiate serotonin syndrome from NMS, where rigidity, not hyperreflexia, is more characteristic. The first step in managing serotonin syndrome is discontinuation of all serotonergic agents. In mild cases, supportive care with IV fluids, close monitoring, and benzodiazepines is often sufficient, and symptoms typically resolve within 24 hours. More severe cases may require aggressive fluid resuscitation, cooling measures, and administration of serotonin antagonists such as chlorheptidine. Chlorheptidine is dosed with a 12 mg loading dose, followed by 4 mg at 6 hours and 4 mg at 14 hours, given orally or via nasogastric tube if needed. For persistent tachycardia, propranolol may be used due to its serotonin antagonism. Intubation is indicated when mental status is compromised or rigidity impairs ventilation. Thank you for participating in our Quality Improvement Initiative. Please complete the post-intervention survey using the provided link to reassess provider knowledge and clinical competence.